Hi guys, welcome again to Intellect Medicos, where learning is made easy. I am Dr. Chirag Matan, and today we will discuss about the management of diabetes mellitus. This is very important for our clinical management and also for our medical examination, right? And this diabetes as a disease is so widespread that yes, we tend to see this in our patient who is visiting in the OPD or coming to the emergency or coming to the ICUs everywhere, right? Even in the neighborhood, even in their families. So we need to know how to manage this disease, that is the diabetes mellitus, right? And in this video, I'll cover everything about the treatment of diabetes, mainly the drugs which are used, the mechanism, dosage, side effects, and also when not to use these medications. So everything will be covered in this video. So please keep watching this video to learn the management of diabetes mellitus. So let's get started. The drugs which are used to control or manage diabetes mellitus can be categorized into 6 classes. Class 1, agents that lower glucose level by their action on liver, muscle, and adipose tissue. And this include bigonides and thiazolidinediones. Class 2, these are the agents that bind to sulphonylureas receptor and stimulate insulin secretion. And this class includes sulphonylureas, MEGLITINIDES, and diphenyladenine derivatives. Class 3, these are the agents that mimic incretin effect or prolonged incretin action. And this class includes GLP-1 receptor agonist or the DPP4 inhibitors, that is dipeptidyl peptidase 4 inhibitors. Class 4, these are the agents that inhibit reabsorption of glucose in kidney, that are the SGLT, right? And coming on to the second class, which is the 5th class, these are the agents that principally slow the intestinal absorption of glucose and includes alpha-glucosidase inhibitors. And the last class, which is the 6th class, includes agents that act by other or ill-defined mechanisms. This class includes pramlintide, bromocriptine, and colsavelam. We're talking about the first class of drugs, which included bigonides. If we talk about the bigonides, they are the first-line drugs for the management of diabetes, right? And this bigonides as a class, it includes metformin and fenformin. Metformin is regarded and taken as the representative of this class. Previously, we had fenformin also, but now it has been discontinued because of lactic acidosis. Now, if we talk about the mechanism of bigonides, these drugs, they activate the enzyme AMP activated protein kinase, right? That is called as AMPK. And also it reduces the hepatic glucose production and improves the glucose utilization in the peripheries, right? So this is the mechanism. Now this metformin, which is the representative, is available in the concentration of 500 milligram, 850 milligram, and 1000 milligram. And commonly we prescribe as 500 milligram once a day, then we keep on increasing the dose according to the tolerability of the patient. Then it is done as 500 milligram twice a day. Then if required, we can go up till 1000 milligram twice a day. That comes out to be 2 grams per day. But if we talk about the maximum limit of giving metformin, it is 850 milligram 3 times a day. That comes out to be 2.55 grams. So the maximum and the upper limit of prescribing metformin is 2.55 gram per day. Above that, you should not prescribe this drug. There is no use. In fact, there is no benefit of adding a higher dose to a patient, right? And also, if we talk about the side effects of metformin, then yes, most common are the GI side effects. Having nausea, vomiting, bloating, and majority of patients, they complain about the GI upset whenever you initiate metformin, right? And that is why it is said you need to start at a slow pace and then gradually increase the dose. Then second is vitamin B12 deficiency. Third side effect is the lactic acidosis. And fourth, yes, it can cause the renal impairment or can precipitate acute kidney injury, right? And if we talk about when not to use or what are the contraindication of adding metformin, the only contraindication is having a eGFR less than 30 ml per minute per 1.73 meter square, right? If the eGFR is less than 30, you should not. That is a contraindication. Whereas if eGFR is between 30 to 45, then you need to use metformin with a caution. So this is all about the metformin or the bigonides. We're talking about the second group of class 1, which is thiazolidinediones. This group or these drugs, they decrease the insulin resistance by binding to PPAR gamma nuclear receptor. And this group that includes troglitazone, which has been withdrawn from the market because of hepatotoxicity. Second is pioglitazone, which is quite commonly associated with bladder cancer. Important for the MCQs as well, right? And you can remember pio as pioglitazone. So pio in Hindi is actually to drink. So more you drink, the more you pee. And you can relate with bladder cancer, right? Just a mnemonic, how to memorize it. Third is rosiglitazone. And this is related to cardiovascular, right? Cardiovascular risk or the events. And you can remember with the rose, right? If you give rose to someone, yes, it is attached. That person is attached to your heart, right? So this is how you can remember. The other side effects which are common with rosi and the pioglitazone are the patient can have fluid overload and can precipitate CHF. Right, and this because of the fluid retention, then yes, there can be weight gain. So these are the other side effects which is related to pioglitazone or rosiglitazone. Apart from that, if we talk about the clinical use of these drugs, yes, pioglitazone is used once daily, and the dosage is 15 to 30 milligram per day, and maximum you can give 45 milligrams, right, per day. If you talk about the rosiglitazone, it can be given either once daily or twice daily, and the dosage, it may vary from 2 to 8 milligrams per day. I hope you are liking this video about diabetes mellitus. And if you want to learn more about medicine and the clinical application, like a patient of myocardial infarction or a heart attack, or a patient of stroke, right, or a patient of GBS, myasthenia gravis. So how to first of all make a diagnosis, how to come to know what is the diagnosis, and how to manage that patient clinically. So with that, along with that learning, you can get a degree from UK, a medicine degree from UK, right? And you don't have to fly to UK. You can give the exam in your country, in India also, right? There are 5 centers in India. So yes, if you want to go ahead learning medicine and also to grab this MRCP degree, kindly see the description below, right? I have attached the link for my other videos of MRCP and also how to go about it, what is there in the course. Okay, till that time, keep watching the treatment of diabetes mellitus. Now, if we talk about the second class of drugs, which includes, first of all, sulphonylureas group. These drugs, they are also called as insulin secretagogues, which means they release insulin by interacting with the ATP-sensitive potassium channels on the beta cells. And these drugs, sulphonylureas, are to be used for the patients who are recently diagnosed less than 5 years, right? And this is categorized into 2 generations, first generation and second generation. First generation sulphonylureas are chlorpropamide, tolbutamide, and tolazamide, right? And these are longer acting, but the problem with these drugs were they have more drug interaction and there is more of hypoglycemic events, and that is why these drugs are not used nowadays. Whereas if we talk about the other one, which is the second generation, quite commonly used nowadays, they are more potent and have less hypoglycemic events. And these drugs, this generation includes glyburide, glipizide, gliclazide, and glimepiride. Right, so these are the 4 drugs, and there are many other, but mainly these four, right? Now, if we talk about the clinical use, first, glyburide. The starting dose is 2.5 milligram per day or less, and the average maintenance dose is 5 to 10 milligram per day. Maintenance doses higher than 20 milligram per day are not recommended. Second, if we talk about glipizide, the maximum dosage is 40 milligram per day, and you start at a dose of 5 milligram per day and go up till 15 milligram per day, but maximum total daily dose is 40 milligram per day. Third, glimepiride. A single daily dose of 1 milligram has been shown to be effective, and recommended maximal daily dose is 8 milligram. And the side effect with these drugs is mainly the hypoglycemic events and the weight gain, although the hypoglycemic events are much less if you compare with the first generation sulfonylureas. And these drugs are contraindicated in renal or hepatic insufficiency. Now, the next group in this class are meglitinides, which includes repaglinides. The mechanism of meglitinides or repaglinide is similar to that of sulfonylureas, but the onset is quite fast and the effect is short-lived. And that is why this drug is used to control the postprandial hyperglycemia. So whenever the patient takes a heavy meal, then yes, this drug's to be used, right? And this is to be used whenever you have an erratic lifestyle or the food habits. And if we talk about the clinical use, it should be used before each meal in a dose of 0.25 to 4 milligram per day, right? And maximum of 16 milligram per day. And the side effect is the hypoglycemia that can happen, and not to be used or contraindicated in patients with liver insufficiency, right? So this drug can be used whenever you have renal impairment or even in the elderlies, but not in liver insufficiency. Now, if we talk about the third group of this class are diphenyladenine derivatives, which includes nataglinide. The mechanism is similar to that of sulfonylureas or meglitinides, right? But the onset is faster than the meglitinides, and even the action is shorter. The side effects remains the same. It is the patient can have hypoglycemic events, and the contraindication is liver insufficiency. And this drug, nataglinide, is available in a form of 60 and 120 milligram tablets. Now comes the third class, in which the first group is GLP-1 agonist. And whenever you take more of oral glucose load, the more is release of insulin, because our gut releases hormone which is called as incretins. Mainly it is the GLP-1. GLP-1 itself is very rapidly metabolized by DPP-4 enzymes, and that is why we use GLP-1 agonist. Now, the more the glucose, the more is the release of insulin, right? With GLP-1 agonist, and the less the glucose, the less is the release of insulin. And that is why these drugs are much preferred whosoever gets hypoglycemic events with sulfonylureas. And that is why many people have shifted from sulfonylureas to GLP-1 agonist, right? And the mechanism, if you talk about, it also decreases the glucagon secretion and also delays gastric emptying. With that, with the effect all of it, what happens is it causes moderate weight loss. And it is preferred in a patients who have a BMI of more than 35 kg per meter square. Right? So then it is preferred in obese patients. Now, if we talk about the clinical use, first, exenatide is dispensed as fixed dose pens of 5 microgram and 10 microgram and is injected subcutaneously within 60 minutes before breakfast and dinner. Second, liraglutide. The treatment is initiated at 0.6 milligram and increased after 1 week to 1.2 milligram daily. And if needed, the maximum dose is 1.8 milligram daily. Third is dulaglutide, that is having a usual dose of 0.75 milligram weekly by subcut injection. So previously it was subcut injection. Nowadays they are available in the oral preparation and many people are using it. even as anti-obesity medication. If we talk about the side effect, it is mainly the GI symptoms, can be nausea and also pancreatitis. And the contraindication or when not to use these drugs are the patients with a renal disease, also the patients with MCT, medullary carcinoma of thyroid. Right? So in these patients, you should not use GLP-1 agonist. The second group in class 3 includes the DPP-4 inhibitors. So these drugs, they inhibit the metabolism of the native GLP-1 and ultimately enhances the incretin effect. This group includes sitagliptin, saxagliptin, and linagliptin. And if we talk about the benefit, they do not cause any weight gain and do not cause hypoglycemic events. And again, many people and many clinicians are diverting towards DPP-4 inhibitors nowadays. And about the clinical use, sitagliptin is given orally as 100 mg once daily, and dosage should be reduced in patients with impaired renal function. So 50 mg if GFR is 30 to 50 ml per minute, and you have to further reduce to 25 mg if it is less than 30 ml per minute. Second, saxagliptin is given orally as 2.5 to 5 mg daily, and dosage adjustment is recommended for patients with renal impairment. Third, linagliptin. The dosage is 5 mg daily orally, and since it is primarily excreted via bile, no dosage adjustment is required in renal failure or renal impairment. And if we talk about the side effects, they mainly can cause rashes and even the SJS, right? The allergic reaction or the SJS. And saxagliptin has been reported to cause pancreatitis. And if we talk about the contraindication, there is no such contraindication for this group of drugs, right? That is for the DPP-4 inhibitors. So this is quite safe to use and well tolerated. Now comes the class 4, which is very important nowadays and very frequently used nowadays. So these are the agents which inhibit the glucose reabsorption in the kidneys by acting on the co-transporter and mainly the PCT, right? Proximal convoluted tubule. And with that, because of less reabsorption, there is more of glucose loss in the urine, right? That is glycosuria, right? And with the loss of glucose, what happens in the proximal convoluted tubule is there's impairment of the sodium reabsorption. And that is why these patients have, these drugs have the diuretic effect also. With that, with more of loss of the water from the body, it is related to, and it has been seen that it causes reduction in the blood pressure around 5 to 6 millimeters mercury, right? And thus is related, and there are many other theories for that, is related with the lower cardiovascular risk. So whenever the patient has cardiovascular risk or any history of cardiovascular, right, then these are the drug of choice nowadays. It's in the guidelines now, right? So you have to add SGLT inhibitors or SGLT2 inhibitors, right? And these include CDE, canagliflozins, dapagliflozin, and empagliflozin. So these are also called as gliflozins. And if we talk about the clinical use, cana is used as 100 mg daily, dapa is used as 10 mg daily, also empa is also used as 10 mg per daily, right? And the side effect, if we talk about the problems with these drugs, is the first and foremost main is recurrent UTI. Even you have to advise to the patient before adding or before prescribing to the patient that yes, these patients can develop recurrent UTIs if they don't maintain a good genital hygiene, right? So you need to inform the patient as well. So first and foremost is recurrent UTI. Why? Because of more glucose load in the urine, right? Because of the glycosuria. Second, yes, these drugs are related to euglycemic decay. Third, yes, these can cause pathological fractures. Then fourth, canagliflozin and empa can cause increase in cholesterol or the LDL levels, whereas dapagliflozin is related to breast and bladder cancer. Now, if we come on to the contraindication of these drugs, the canagliflozin and empagliflozin are to be not used whenever the GFR is less than 45 ml per minute per 1.732 meter square. Whereas for the dapagliflozin, they are not to be used whenever the eGFR is less than 60 ml per minute. Right? So this was about the SGLT2 inhibitors, very, very important clinically and also for your MCQs and medical examinations. Now coming on to the fifth class of drugs, which includes alpha-glucosidase inhibitors, which includes acarbose, miglitol, and voglibose. Now, what these drugs do is they inhibit the enzyme which degrades oligosaccharides into simple sugar, and ultimately they decrease postprandial hyperglycemia, but they are not doing anything with the insulin secretion, right? So they inhibit the absorption of the carbohydrate or the glucose. Now, the clinical use is acarbose should be used started in the evening and then you gradually increase it. So you start with 50 milligram twice daily and then you increase to 100 milligram thrice daily. Whereas miglitol to be given as 25 milligram thrice daily. And the side effect, if we talk about, because of that undigested carbohydrate in the intestinal lumen, these patients have the problem with the abdominal pain, flatulence, or the diarrhea. Also, these patients can have derangement of the liver enzymes, and these patients can have hypoglycemic events if used with sulphonylureas. Now comes the sixth class of drug, and that is the last class. We're having an ill-defined mechanism. That means we do not know the exact mechanism how they act. And it includes pramlintide, bromocriptine, and colesevelam. So pramlintide, it's an amylin derivative or the analog, and it reduces the appetite centrally. Also, it reduces the glucagon secretion and delays the gastric emptying. Whereas if we talk about the bromocriptine and colesevelam, we do not know the exact mechanism how do they cause decrease in glucose levels, right? But colesevelam is a bile acid sequestrant and also it reduces the cholesterol levels. The side effects of all these three are mainly the GI side effects, right? Having the nausea and flatulence and all those things. So that was all about the treatment or the medication used in the management of diabetes mellitus type 2. Right? And the mainstay, the first thing you should start is the lifestyle modification, having the diet control, and secondly, the exercise. If not controlled on this, then you have to move with the pharmacological methods, and these are the drugs which we have discussed in our session or in this video. And you can connect with us on our Instagram handle by intellect.medicos, and also, yes, you know about the YouTube, that is Intellect Medicos. Keep watching it, and if you have not subscribed, please subscribe because I'll be coming with more of content on this channel. Okay, bye-bye, take care.